so often there, it's now here. So welcome to Flybe, and I'd like to thank Flybe for looking after us today. I'm Robert McElroyth, I'm the chair of ExIST, and I just want to do a very brief introduction, and then I'll hand over to Robin Jackson, who will introduce the speakers and talk about how today is going to go. I'll do the fire alarm because, you know, we're really unlucky if there was a fire alarm in the 10 minutes I'm going to be on before Robin gets up, but you have to either go down those stairs or you go right to the far end of the corridor to get out. They are signposted. Hopefully, of course, there will be no need for that. We're delighted today to have 4 speakers on the subject of healthcare. They're really important topics to us, and I think you'll be surprised by how much is going on in the Exeter area in the area of healthcare in science and technology. You know, ExIST's role is to raise awareness of science and technology throughout our, the catchment area of Exeter, and healthcare is a really important subject for us, and you'll realise today how many great things are going on in that area. As always, well, first of all, you've got a copy of ExIST's latest copy of Insight. That's the 4th one we've done now. When we started that, we weren't sure whether we would be able to get to the 2nd or 3rd, but we've carried on, and we're very confident we'll keep doing that. We're always looking for subject matter, and if you feel you've got topics that you think you can let us have, that you want us to talk about, publicise, we're very happy to do that. So do that to the Chamber of Commerce. The Chamber is our main sponsor, in effect, because we started as a Chamber initiative many years ago, and the Chamber is the organisation that gives us the greatest support. But outside of that, we have a number of sponsors who are all on the bottom here. We're thinking of getting bigger slides because we have more and more sponsors, and we're incredibly grateful to the sponsors for allowing us to not only put it on events like this, get speakers to come to tell everybody what's going on, but also to produce things like Insight and to hold other events. So, as always, we're very grateful to them. Robin will tell you all about the speakers, and that leads me to Robin himself. I'm sure he'd be severely embarrassed to know I'm going to talk about him for a minute now. Some of you might know Robin, and if you don't, you should. He's going to get up and tell us a few things. But Robin started ExIST with the Chamber of Commerce. It was his initiative to create what became ExIST. And without his foresight and support from the Chamber, it wouldn't have happened. And in the last few months, he's decided to leave us and go and work in Cornwall, which is a shock, but Cornwall's gain is definitely our loss. So we've got him today for kind of the last time doing this, although he has promised to come along on other events and see us. I cannot tell you how important Robin's been to ExIST. He's, any of these events, he's effectively organised, with enormous support as well, but he's found the speakers, got them to create the topics, link it to one overall subject. He's managed to get them to get their presentations down to 20 minutes, which I can assure you is not easy. You know, some speakers, when they get up, if they could speak until the next quarterly meeting, they would. But Robin has managed to sort that out over time. And, you know, when you think for 6 years, effectively every 3 months, we have had one of these events, and we've had new speakers or revised topics every time. It's remarkable, really, because we weren't sure when we started ExIST whether we'd ever get more than a couple of talks. Just show you what goes on in Exeter. Robin has been the driver behind that, and his passion for ExIST and his support for it has been immense. So we bought him a small gift, which is hidden right here, which I'd like to give him at this event, because I think he deserves our applause and thanks for what he's done. The very last thing I want to say, because he's going to come up now, I'll give him 1 minute to recover from that. There's a big white cross on the floor, and the speakers have to stand on this cross. If you see a speaker move, at least even 6 inches, you just have to wait, and they will go back, okay? So that's your job. Because while they stand on this cross, they can be filmed. Is that right, Alex? Yes, mostly right, yes. And if you could speak loud, that would be really great. I'm going to hand over to Robin. I hope you have a lovely event. I do have to leave now, but thank you for coming, and I'll give you Robin. Thank you.
Thank you, Robert. You see, I've made him leave the room. It's interesting. Yes, I'm leaving ExIST. I am now the Agritech Cornwall Director. One thing I'd say about Agritech and healthcare and big data in particular is that AI in big data does not mean the same thing to farmers. AI is artificial insemination. So when you talk about using AI for decision making, it actually gives, it really raises a few eyebrows. That said, today's topic is healthcare. There's an elephant in the room, and may I actually just kind of expose the elephant in the room. It's the big and structural problems that we have with the NHS. And this event is actually not to focus on that, because I think we would spend a month of Sundays discussing that matter and never even scratch the surface. This event is actually about informed decision-making in healthcare, how to actually make healthcare more responsive, more appropriate, better informed, and in particular, we're really lucky to have some great examples, different examples of how this can be done from companies and researchers in our region who are applying this not just regionally, nationally, and to that extent internationally. So we've got a very varied lineup today, and without further ado, if I may introduce Colin Richman, who, as a practitioner starting in pharmacy, recognised significant problems within NHS pharmacies and how better to make them effective and better informed, created with a co-founder, RxInfo, who are based at the Science Park and doing great things. So, Colin, may I invite you up to the podium?
It's all yours. Thank you very much, Robin. Well, there's only one way to start this. Choose life. Choose a job. Choose a career. Choose a family. I've got to stay on this spot as well. Choose a big television. Choose washing machines, cars, compact disc players, electric tin openers. Choose good health, low cholesterol. We have a £7.6 billion drug problem, okay? This is not actually what you're thinking about, I hope. Well, what's the size of the problem? Well, we were going to start this and put out just an idea of the spend on medicines within healthcare. As an intervention, in healthcare, a prescription, medicines are probably the single biggest thing that take place within healthcare as a treatment modality. So what was the spend in that? It's actually fairly big numbers. So it's we're looking at around about £16.8 billion per annum spend, and that is growing at an alarming rate. So we can see here from this chart, this is the data from 2011 up to last year, and we can see the blue bit down here being hospital spend, the white bit up here being GP spend, and the very light blue up at the top being fairly insignificant, of only about a couple of £1 million, but is basically to do with a different type of prescription in there. So where's the growth occurring? Well, we can see here that hospitals accounted previously for about 40–45% of spend, and that is going up, and this year will be a landmark bit. It will actually exceed the spend of GPs. Now, when you consider there are over 7,500 GP practices and around about 230 NHS secondary care organisations, they're spending a fair amount, aren't they? So next, this is what's happening in hospital spend, 12 to 15% growth in spend on medicines. Okay. So it's growing, it's accelerating, and what are we trying to look at within that? Well, okay, what are the drivers? What's coming along there? Well, things with fantastic endings. Things that end in MAB, ending in NIB, they cost a lot of money. Okay. Things that end in VIA, things that end in SEPT, they actually do mean things. The stems of drugs are actually quite good. So an MAB is monoclonal antibody. NIB is it's angiogenesis inhibitor in there. VIR, antiviral. So you can see where these things are coming, receptor antagonists and things like that. And then other drugs like lenalidomide, which was related to thalidomide, and still has the potential birth problems, but is used very importantly in haematology complaints and things like that. What other drivers are there? Why are we seeing this growth in hospitals? Well, we're seeing that around genetic testing. Genome mapping is now going to be coming in. We've seen Dame Sally Davies talking about this now, that we should be starting to genome map cancer patients to understand what treatments are going to work, the identification of those treatments on there. This is not going to be inexpensive. Okay. The other thing, of course, is population demographics. We're all getting older, we're all living longer, and we're not dying of the things which were quite cheap. We're now dying of things which are a lot more expensive. I'm taking a very flippant view on there, but that is a health economic point of view where it comes from. So population demographics mean that we are going to see more dementia. We're going to see more diseases of old age coming in. And the more that we're successful in treating the easier things, the more expensive healthcare is going to go. This was from a fantastic source. It's the Daily Mail. And they were reporting big shock horror story, top 10 costly drugs in 15-16. Those of you that are very astute and do maths, you'll notice that though the Daily Mail do point out to politicians when they get their numbers wrong, they've got their comma. Should have been a decimal point. Now, either they're using the European Convention, which I'm not sure they're going to admit, but we can see there. So change your commas to decimal points, and you'll actually see the spend per annum on certain top 10 drugs, and they are quite huge. I have actually got a reference for that as well, so any of you that would like to have a dig at the Daily Mail, you're very welcome to. Okay, so key trends. We've said health costs for the NHS. So it's around about a per capita cost of over £2,000. And we've got £120 billion in the 16-17 period. As we said earlier, hospital spend will start to overtake primary care. And there's a continual upward cost pressure that we've discussed. So how do we counteract this? How do we counteract this? This is about cost savings management initiatives, and we've heard things. Some of you may be familiar with Lord Patrick Carter's work, looking at hospital efficiencies, and that's in 4 particular areas, one of those being pharmacy. We've also looked at ageing population, and those of you that would really love to have a look, there's a very useful and very enlightening article, this time from The Guardian rather than Daily Mail. So what are the downward pressures? How do we create the downward pressure within the NHS on medicine spend? We know that there's upward pressure because of all of these items, the technologies, the age of patients, and what we can do. But how do we handle this? Well, there are a couple of technical things that go on within the NHS. We've got price management mechanisms, so PPRS, Prescription Price Renegotiation System, which basically is bundle all the drugs from a particular company that choose to join in. It's a kind of a career limiting move if you don't join it. That's the kind of way government handles it. And they apply a downward pressure on there. So they say, in your basket of drugs, some of these we will allow you to gain your profit from, but some of those which are older drugs, older technologies, we need to see a downward pressure to create an overall agreed percentage increase in there. So it's actually quite a hard negotiation that takes place there. Category C is a technical term as well, and Category C is to do with a way that drugs get reimbursed to pharmacies in primary care. And interestingly, what we've seen has been related to the big issue in America. Do you remember Shkreli? And the issue with Daraprim, pyrimethamine to any pharmacists out there, where he basically took a very cheap as chips drug and made it cost $750 per month for HIV patients. And decided there wasn't anything. I think he degoused his moral compass on the way past something, but it wasn't good. To give you an idea, Daraprim, so he's charging $750 for monthly treatment. Anyone want to hazard a guess what we would pay in the NHS for that drug? About £1. So somebody who's basically taken proverbial on that. Now, what's happening in the UK? We're not immune to this. So what's happening in some areas of the market, and we're seeing cost inflation to basically pay for increases in profit, and drugs are going out of this Category C into another category called Category A, whereby there is no downward pressure on that area. So we've seen drugs, so very simple drugs, which have been around even over 100 years. So there's no claim of, oh, I've got to get my R&D costs back. That doesn't wash. So phenytoin has been in the market on this. Prednisolone soluble tablets. I mean, these are basically cheap as chips a lot of the time. However, that has increased the phenytoin by hundreds of percents, and the prednisolone soluble by around about 1,000%. Okay. So we're seeing real drivers in the market to squeeze more money out of older technologies. And when you are short on that, you can preserve your market, you can have processes in there. These are things that need to be fed back into the health service to actually help the downward pressure, because these are upward pressures from economics and demographics coming into here. Patient reviews, a lot of my pharmacy colleagues, and a lot of direction within pharmacy is around about reviewing patients' medicines. So when we see older patients, you'll see polypharmacy, so a lot of drugs going into a patient's therapy. So we see patient reviews, and this is actually about sense. It's like, well, why did we start this? Well, that's no longer an issue. We should get rid of that. And in fact, the reason you're taking that drug is because it's a side effect of that drug. Let's get rid of both of those, and you can start to diminish the number of medicines patients are using. 1, great for their health. 2, good for the bottom line. So it's a very useful thing, and it's a rescheduling of what we are doing as a profession. Sharing of care. So a patient may start in a hospital environment with a treatment, but then will be moved to be treated underneath their general practitioner. and they will share the care. So the expertise is there, but the prescription, because it's also VAT efficient through primary care, is better delivered through primary care. So lots of innovations going on. VAT efficient supplies, so home care and VAT, I'm going to not say, what am I not allowed to say? Not evading, but avoiding. That's right, that's the way. So it's, that's what's going on there. Obviously, in a macroeconomic point of view, it doesn't matter. Microeconomics within the health service, worth 20%, so it's pretty good. And then the Carter Review, which has been taking place. So, come back to my £7.6 billion drug problem. Not mine personally, I'd like to point that out. So what was the problem? Well, until 2013, the NHS did not have a system that could show them hospital spend data. Okay, so which other industry would you have £7.6 billion worth of spend going on and not really have a handle on where it was going? So there were information which was coming from separate sources that was helping to inform the process, but never has there been the in-depth information. So I'm going to give you a nice highbrow quote here, seeing I've gone to pop culture, I'll go to Galileo now. Measure what is measurable and make measurable what is not so. So that was perhaps the inspiration, and my background as a pharmacist hopefully helped a great deal in doing this. So our journey as a company. I've been going since 2003 when I incorporated RxInfo. And we went in this process and this journey for this part of benchmarking hospital medicines use. We went from 4 alpha sites, West Midlands sites there, who agreed to join and be part of IDEA, to 40 beta test sites and to 145 user sites. So we've got there. Probably one of the biggest challenges that we singly had in the whole of the process was working with over 200 NHS IT departments, and frankly that has been something to lose sleep over. It's, you know, as we saw recently with the big technological issue that hit the hacking and encryption bug that went through. Basically, you know, there are a huge amount of variation within, or there is a huge amount of variation with NHS IT departments. We've worked with them, we know them. So our key bit. We had to standardise all this data. And to give you an idea, I mean, there's a huge amount of data in there. We have about 14 different data feeds, all of them that could be free text. So, frankly, you could have blue banana tablets and it meant something. And we would have to understand what that meant and map it to the standard. And we've had to do that 1.925 million times. Okay? It's a huge, huge undertaking that we've done. And now we have a standard of data with all the data feeds that come from many different forms and many different sources, and built that up. So almost like a geological strata, we now have nigh on 100% for each of those NHS secondary care organisations. So the process data, so we are the data processors. We standardise this, we get the data in, we standardise it, we basically munge it, we turn it into something which is actually going to have value. So where has it been used? Well, it's been used in hospital savings plans. I've sent people away from training sessions that we do with around about £250,000 to £500,000 of savings that we've identified within a couple of minutes of looking at their data. You know, do you remember the dunnhumby, the company that did Tesco Club Card, and the comment that came back from the chief exec at the time? How do you know more about my organisation in 3 months than I have done over 30 years of working in the organisation? That is what we are able to do with this data. I'm preaching to the converted here because you know what the power of data is. Our information has been used in the Parliamentary Health Select Committee. This is around about the monopoly generics, what we talked about the Category C going to Category A, the price increasing. They call it price gouging. So basically, yeah, we bought the drug licence, and now we're going to make as much money as we can from it. We've had regional procurement areas using data to actually help in the purchase of medicines and understanding how they're buying in medicines. And also Public Health England have used this in their antimicrobial stewardship. So second biggest risk to the population after terrorism. That's how the government have called it. And we're being able to now help and actually show people how things are happening, how they're using their antimicrobials in there. So we feel kind of really happy with how the data is now being used. And then as we talk about the Carter Review, and the quote that came back from the person or the people who've been leading the Carter Review for secondary care has been, without your data, we could not have done this piece of work. So that's kind of air pump moment. Excellent. So stats and facts, we've already talked. Standardised 1.925 million drugs. We apply specialisation, so another part of the standardisation process is around about making sure that the cost centres, Ward 1, well, what does Ward 1 do? Because I'm going to have to benchmark this somehow. I can benchmark it against another Ward 1. It's not going to help. But I need to know if this is neurology, urology, cardiology. So we standardise that. And we have about 65% of that done, because when we see Mr. Smith or Dr. Jones sitting in there, frankly, I don't know. We have to work with the organisation to do that. We have to account for 14 different data sources, so different flavours of data coming into the system. We have to reallocate data based on which organisation pays for it. So, for example, here in Exeter, they supply Devon Partnership Trust, the mental health organisation. So we have to take a slice off their data and give that to Devon Partnership Trust. But also Devon Partnership Trust gets stuff from North Devon, South Devon and Plymouth. So we have to build up their data to give them a true representation of their data and a true representation of others' data. We also add in high-value additional information into there. So has this service been delivered by a concept called home care? Has it been, what other things do we need to know? Is it a parenteral nutrition product? Things like that. And we also cross-reference data to international standards. So I've got a picture of Norway on there, because that's where the World Health Organisation is based on there. And underpinning the whole data, it's a fairly big data set. I wouldn't claim it's massive data, but we've got just about 750 million drug transaction lines sitting underneath this data, and we go back to April 2011. So we're starting to be able to understand trends that have been happening. So how do we provide it? Well, as easy as we can. The whole principle has been very much around, is it Google simple? It's a white screen. There's not a huge amount on this screen, so people can log in, people can get to see what they do. And we have a series of things. So once we've standardised data and we have a data platform underneath here, we can then build reports on the top of that, and they sit within family and classes of products. So Define is about benchmarking. It's about hospital benchmarking on there. Refine is an inward look to your own organisation and accountability, if you like. So who's been prescribing this thing? So, for example, in Define, you find out that your urology department is using a lot of coamoxiclav, twice as much as the national average. You can then draw back into your own organisation to understand which prescribers within your organisation are doing that. So it's very much about accountability in there. Adios was put in place following the Harold Shipman case, and it's looking at diversion of basically abusable drugs within hospitals, and Steve over there has helped us with some of the technologies behind there to actually understand and doing the statistics to actually pull out aberrant behaviour within there, so looking at things which are abnormal. Emergency drug box, cardiac drug boxes and where they go around. Translabel, it's a nice one, we provide that one free of charge, but allows people who do not have English as a primary language to actually have a label that they can read and see, and it's a translation between English and 41 different languages, and another Exeter company's helped us with that one, so that's been fantastic. And we're bringing out parity shortly. VEND is valuing expiring NHS drugs, so it's a backronym for that. And it basically is a platform within the NHS to minimise wastage. Anyone want to hazard a guess at how much is wasted on medicines per annum?
3 billion.
Fortunately, not that much. We've got around about, well, we know for certain about £12.7 million get wasted, thrown away. Okay, and that'll be because a patient no longer requires that. We can't return this to a wholesaler. You're stuck with stock that you're not going to use. So we reckon the figure is actually upward of 50 billion, because we understand that people do not always book things out to their right wastage location. So we expect this is around about £50 million saving per annum the NHS can make. And this is by actually putting a platform in place to say this is there. And of course we can leverage the platform data to say, you guys have been using this data. So it's great. So you can see what we're starting to try and do with the information and trying to create this inward, downward pressure on NHS spend. So this is some of the output that we see in the data set. So these are the things that become issues. And we've tried to pick out things which are sort of more headlines, so you'll probably be familiar with. So these are 3 non-steroidal anti-inflammatory drugs, painkillers, to you and me. Basically, these are the number of doses that have been used and the proportion of those by each of the regions within England on there. And basically, what we're seeing here are the 3 big players in the market. You've got in light blue on the far side there, ibuprofen, then naproxen in the orange, and then darker one, diclofenac. And diclofenac had a Medicines Health reporting agencies warning to say that patients with cardiac risk should not be taking this. So as an indicator, we want to understand who's using more of it proportionally, because it may be that information has got through, that you're putting potentially patients at risk because of that. And what we've actually found is this picture has changed since 2013, hugely. Diclofenac was the primary entrant in the market, and now it's all the way down here. But we can still see pockets of larger use, and it's been interesting because we've seen a lot of it go away, but some come back now, but within obstetrics, where it actually isn't going to cause cardiac problems in there, but we would not expect to see this in a cardiology or even a gastroenterology type ward. So that's stuff we can start to understand. We feed back into the NHS to understand how changes have gone. You see that? Okay, yeah, fantastic. This is big technological innovations that are taking place at the moment, where we've had the MAB drugs, monoclonal antibody drugs. We are aware that the usage of these drugs, in this case is a drug called infliximab, used for Crohn's disease, sometimes for dermatology, sometimes paediatric patients. And key bit there is around the two products, the biosimilars, which are equivalent drugs. You can't quite call them generics as we normally have within there, but a bioequivalent drug, and the originator product on there. And we can see the originator in number of doses increasing and increasing and increasing, and then this precipitous drop in the use and the increase in the biosimilar. Okay, so that's what we're starting to see on a national basis for the uptake of these biosimilar products. And this is worth probably around about £200 to £300 million to the NHS. That's what the spend is on there. We see the increase in the use there. The right-hand chart indicates the overall spend. So even though those of you with sort of like good ideas of sort of pushing the data forward, you can actually start to see that we're actually using a lot more of the data within here, a lot more of the biosimilar within here, and it's actually increased the overall usage. So we're actually treating patients earlier with these technologies. Okay, again, we were blind to this. So these technologies are coming in, and the cost has come down. So this is actually fantastic. From a macroeconomic point of view, again, we're now able to see that we're treating these patients potentially with Crohn's disease, potentially rheumatoid arthritis, equivalent drugs in here, earlier, which means that they are not having disability, as greater disability problems, and we're actually being able to actually put out these more expensive technologies, but to a wider audience, which I think is hugely, hugely valuable. We'll see one of the big blockbuster drugs starting to appear in this, so we're expecting that in about 2018 on there, and that one's worth around about £400 million per annum. We'll expect to see that price probably halve. So quite incredible on there. And then my final slide here, 4 questions, is around about antimicrobial usage. So these are the ways that we are starting to represent the data, and we train people on how to interpret this data, because not many of my clinical colleagues have that background yet, but we're working on it, we're educating them. But here is an indication of antimicrobial use. And again, this is across the whole country, so you get to see a national picture of antimicrobial use. And what we're looking at is number of doses per 1,000 hospital admissions, so it's a weighted figure in here. We've got quadrants in here. So this is taken from a Boston matrix, which is the pharma industry's idea of marketing. We've been able to take the concept and reuse it, which I like. And basically here, we actually start to understand about the quadrants of how these medicines have been used. Dark blocks there, teaching hospitals. Blue blocks there are acute hospital trusts. And we can see the scatter around there. The line up middle is the mean usage per admission. So that's the average across our country on there. And the growth here, the line, zero line here, indicates there is growth or decrease in the amount of antimicrobial used. And as you'll be familiar, antimicrobial stewardship is in trying to get people to start smart and then focus, which basically means start them on a treatment, but make sure you're getting blood cultures, make sure you're getting the biochemistry back, because you need to then focus in on the drug with the correct antimicrobial to treat it. So you shouldn't be using broad-spectrum antibiotics for more than 3 days, ideally. So, and what we're starting to see here, and what we can start to do with the data, is actually show how that impact and that change has been taking place. And it's been fascinating to see the shifts that have taken place within a 12-month period. It has been quite incredible. And I think a lot of this is about people being able to access this type of information, to be able to interpret that if you sit top right here, you're probably going the wrong way and you're using more. Okay, this isn't a great place to be. You want to be down bottom left if you can, because that means you are using these medications more effectively or more targetedly, and you're also decreasing your use based on the reference period on there. So those are some of the things that we can do with this data set. And we've built the design of the whole system so that whether you're a chief pharmacist, whether you're a Department of Health, whether you're a clinical pharmacist working with patients, you can go away, you can find this information, and you don't have to have a fantastic degree and understand medicine statistics. You can come to this information very, very swiftly and identify and understand what's going on there. I'm going to wrap up at that point and take questions, if that's okay.
Thank you. So, questions? Colin? Chris?
Hi, Chris Lorimer from Southwest Gregson. I remember watching an excellent film by Sir Ken Robinson about the use of Richman in the States and
Yeah.
how different states prefer to use it to treat people who suggested they had ADHD. And he was using this to expose to bizarre behaviours in regional areas in the state. I suspect you're finding a load of those sort of insights coming from your analysis across the UK about not Britain, but all sorts of drugs. Right?
There's clearly variation. I mean, that is, as I said earlier, that speaking to people when we do our training sessions, we're able to say, in your organisation, you do these things quite differently to everyone else. Why? And we'll sometimes have good rational explanations for that, other times not. I mean, sometimes it will be about cost, sometimes it will be about clinical behaviours and things like that. We don't tend to see as much of variation because we have the overarching bodies called NICE and things like that that actually give guidance that all NHS should abide by. And I think that is very, very helpful in actually providing sort of parity across organisations of understanding that. So we see variation, but hopefully not within sort of like the bizarre end of the spectrum. Not impossible, though.
Hi, excellent presentation.
Thank you.
Very much. And really interesting to see how you're tying together the information from a variety of different sources. That's a little bit different.
Yeah.
But most of your discussion was about money. Right? Towards the end,
Yeah.
you did mention with Crohn's disease, that's a benefit
Yeah.
treating earlier.
Yeah.
And you talked in terms of negotiation with drug companies about, basically bidding down on price. Could you not tie it to the benefit?
Yes.
That you cause them to prove that you're getting benefit? Because presumably we don't want to be spending nothing on drugs.
Absolutely. I absolutely agree with that. I mean, I take the financial point of view because unfortunately within healthcare that is probably one of the biggest risks as we're seeing reduction in overall funding to the NHS. And I think 18-19 is going to be an exceptionally difficult year. So it's very much, we've been working with the Carter Group, so hence that's why my focus on the money. But clinically, I mean, this is huge. Can we show benefit? No, because that's trying to connect other data sets. There is something called the Health Episode Statistics data set, which is valuable, but the people who run that one keep it very closely guarded and want to...
You're trying to beat them down on price, an adversarial thing with the suppliers, whereas if you could tie it to the benefit,
Yeah.
they would work together.
Absolutely, and I agree with you that the outcomes are there, and what we've seen with the biosimilars is very much that you're starting to treat patients earlier. So where it's been a real big barrier to get to that product, that is now moving backwards. So it's treating patients earlier, which should have macroeconomic benefits. But of course, when you're looking at macroeconomy, it doesn't help the NHS. It might help social services. It may help disability and work benefits. But of course, that's not within their envelope.
Benefit doesn't need to be in terms of money; it could be in terms of
Outcome.
health.
Yeah, absolutely. So,
Thank you. John?
Hi, John Terry from the University of Oxford. Really enjoyed your talk.
Thank you.
I wondered, moving forward, how things like clinical definitions of treatment responsiveness might feed into this. So at the moment, lots of people are on drugs that actually may not be effective for them, these modalities as well as choice for a particular condition.
Yeah.
I wondered how those sorts of issues feed into all of this economic analysis.
fine. I think the direction of travel for the NHS at the moment is towards something called GS1, which will be their overarching standardisation. So General Standard 1, it's called. With that, theoretically, the idea behind all of this is every input, so basically drug, treatment, operation, type of condition will all be coded at a patient level. So patients will have an individual identifier. The drugs and everything else will have that. That's what we're helping with at the moment. And then on top of that, you'll have practitioner IDs as well. And when that information all comes together, that is where it will be hugely valuable. And that's where I believe, you know, the metrics of what we can do and where we can actually sort of drill into information, understand what's been happening with medicines and the clinical outcomes will start to be available. We're not there by any means yet. I mean, if we're talking about 2013 was the first oversight of secondary care NHS drug spend, you know, we've got still some way to travel. It is travelling there and it's getting faster. Yeah, it will get there.
Do we have time for one more question? We do.
Yes.
Can I have one more question? Another jump.
Yeah, Phil Johnson from South West Growth Service. Do you work with people like British Society of Gastroenterology, where IBD standards and guidelines are made by a corporate group of physicians who then cascade to the masses of fellow consultants?
Not formally, however informally, been doing a block of work with Professor Alan Lobo up in Sheffield, and very much so. So there's going to be a piece of published work coming out directed from there. It's stuff that we want to do, and we want to actually use this in publication a lot more.
Talk afterwards.
Okay.
Thank you very much. So, Colin, thank you so much for that. And actually, that's quite a good point to end on. So, if you want to discuss with our presenters afterwards, we've got
very, very happy to do that.
The slides, I gather, will be released as to anybody that wants them. They'll be put on the ExIST website, or if you want to contact Ali in the chamber team, we can give you the slides as well. And of course, it's live streaming. You'll be on YouTube, so we'll be on YouTube. So be very afraid. Thank you very much.
Thank you very much indeed.
So we now come to quite a challenge. When you're receiving data like this, and you can see right down there's a little black dot. And technically that means there is an exceptionally well-performing teaching hospital who is using much less antibacterials. And so they're doing something different. And how do you culturally, rather than in a sense from a top-down directive, actually help spot innovation and best practice? And this is where we're very lucky to have Jason Williams of Seedata. And Seedata have established a platform which helps the NHS address just that. Sorry, we've now managed to get into editing of an embedded file. See, I'm a technologist. Ta-da! Wonderful, thank you so much. Jason, hopefully that didn't detriment your dumb roll. Yeah. I have now broken your presentation, please.
Hopefully we'll be able to get to the next slide. Thank you very much for the introduction, Robin. As I said, Jason Williamson from Seedata. We're a software company based just down the road at Exeter Science Park, previously of the Innovation Centre. And as Robin said, we've developed a web platform specifically for use in healthcare. It is essentially a project management system, but it's geared up very much to help health and social care organisations run quality improvement projects. And that's quality in the fairly broad sense of quality. We're often looking at safety, sort of patient safety type issues, looking at maintaining, if not improving, the quality of care and the effectiveness of care, and also making sure that the delivery of that care is as cost effective as possible. And it's essentially a project management system to help them do that. I'll tell you a bit about that and a bit about the journey and a bit about how it's helping people address some of the challenges that we face in the healthcare sector, not just in this country, but in countries around the world. So the three sort of topics I'm going to talk about is about how the platform is enabling effective improvement at any scale, how we've managed to spread the use of that, and how that then in turn is helping us generate this sort of integrated global knowledge base of improvement work that's taking place that others can essentially steal from and help improve their local context, their local health systems, their local hospitals by grabbing the great ideas from other parts of the world and also learning from the mistakes and failures that others have already made. So the first bit about enabling effective improvement at any scale. So as I said, it's a web platform that people run their projects on. It's been around for about 2 years now, and it started out here in the UK, very much here in the southwest. Initially, it was a collaboration with a part of the NHS based down here, the Academic Health Science Network, or the AHSN, who are based here, who were previously at the Innovation Centre. We developed the system with them, and it started to be used predominantly by the hospitals here in the southwest of the country, and then its use spread in the southwest. Soon became apparent that it was quite useful, others could make use of it, and so it spread across the NHS, particularly in England to begin with. And I'll talk a bit more about the spread in a minute. But we've got everywhere, anywhere from a primary care practice with one GP, one practice manager who are running one small improvement initiative, right through to major hospital trusts who have 1,000 people working on improvement projects, running sort of 250, 300 projects at any one time, through to some regional, even national collaborative pieces of work. So there's things like the maternity and neonatal safety collaborative that's just kicking off at the moment, which is a 3-year national initiative that will involve 50, 60 trusts from around the country working on maternity issues. This is a platform that allows them to all run their projects all in one place, to share data with each other, to work, to collaborate together on the same project. So it's there you've got hundreds of projects taking place, and everyone can work together on the same projects, right through to your local GP surgery who can just run their projects, or they can run their projects and the GP surgery down the road here can see what's going on in Newcastle. They can work together on a project, they can share their data, etc. It allows them to whatever's relevant to the scale and the topic in which they're operating. It's not just about prescribing medicines, for example, it's all sorts of range of issues that they're trying to tackle. So the system here in the UK has now got about 2,000 active improvement projects, and the range of topics is quite phenomenal. So it's working really quite well. How does it do that? How does it enable them to improve? How is it different to any other project management system? Well, the key thing is, I say project management, but it's not your generic project management system. It's not Gantt charts and risk logs and things like that. It's geared up entirely around the improvement methodology that's mainly used in healthcare, which is called the model for improvement. And some of the elements are highlighted on the slides here. So it's about driver diagrams. What's your aim? What are the main things that will help drive towards that aim? And kind of breaking it down into a bit of a process map to say what are the secondary drivers, what are the change ideas, what are the small things you could change that, if they work, will trickle up and have an effect on your overall aim. PDSA cycles, plan, do, study, act cycles. The idea is that you try and take a bite-sized problem. What could we do? What could we change next week and test it to see whether it makes a difference? And if that works, how can we then make that bigger? So rather than spending 6 months planning the initiative or the implementation, actually what can you do next week? How can you iterate that? How can you improve that? How can you start small and then scale up? And allowing them to do very rapid sort of tests of change. But then perhaps the key thing is then when you're making these small changes is how you visualize the data, how you visualize the impact. And is that impact significant? And importantly, is it statistically significant? You might change something and the data appears to get better, but is that because you changed something? Is it significant enough that you need to keep doing it, or actually do you need to do something else? So one of the big shifts and one of the big parts of methodology is SPC charting, so statistical process control charting. Basically, it looks like a line chart, but it's looking for instances of special cause variation, so variation in the system that is statistically significant. It's only when you look at that can you really hone on what's making a difference. And that's one of the sort of the big innovations. Like, we haven't created SPC charting, it's been around for years and we're not statisticians. What we're doing is creating a platform that presents all of this to the clinicians so they can, as easily as possible, run these projects, chart the data, figure out if the changes that they're making are having a positive effect. So what we're seeing is hospitals moving away from data like this. So this is an actual scorecard from a hospital board in London. This is quite old now, this is back in 2009. This is what the board looked at one Thursday afternoon. They had their board meeting. Lots of detail, you're not really meant to read it, but the board look at it and broadly it's all green. Everything looks great. There's a couple of little ambers where they're about a couple of % off their 95% target, but it's always like that and every hospital's like that, so they're not really particularly worried. So they all go away Thursday afternoon thinking, great, everything's working fine. And the chap that told me this story is the nursing director there. He then went on holiday Friday morning, great, gonna have a nice long weekend away. He gets a phone call just as he arrives at his holiday cottage from the medical director. I'm sorry, but you need to come back. One of our patients has just murdered another patient on one of our wards. It's like, oh, okay, so maybe things aren't quite as hunky-dory as we thought they were. And you begin, so a lot of investigation, figure out what's going on, what can we do to improve. You think maybe it's just a bit of a one-off, bit of a freak sort of incident, don't need to worry about it too much, maybe not. Inside a year, that hospital appears on The Guardian because 3 patients have died on the same ward. 1 murder and 2 suicides. All of a sudden, the data that they were looking at was showing them one picture, but the reality of what's going on within their hospital was very different, and they didn't really have a way of tackling it and addressing it. So that's when they begin to adopt this improvement methodology that's widely used, and we only play one part in that jigsaw. We provide them the web platform, we provide them some resource and some tools to help them deliver those projects. Fundamentally, these organisations are making a kind of cultural change. They're starting to embed this sort of improvement methodology in the way that they work, and then they use the platform that we've created to help them chart those projects, to help them understand what's going on. What do we need to improve in our hospital? How are we improving? What can we learn from others that are doing this down the road? Where are the hotspots? Where are the people that have tried something and it hasn't worked? And how can we learn from that and not make the same mistakes they did? So they've gone from being on the front page of The Guardian to actually being one of the leading organisations in the world at healthcare improvement. And I'm not really meant to tell you who they are because of the sort of publicity that they have got in the past. But they're doing this on a huge scale now, and they're going around the world telling others how to do it. So, and that's not just because of our platform, but it plays a part in helping them significantly improve the quality of care that they deliver, all within the same financial constraints that everyone else is operating. So they haven't got any more money than anyone else. They operate in a very difficult climate in part of London, and they're a mental health trust, so it's not easy. Some of the things they're dealing with are really quite difficult challenges, but they've been able to make some significant improvements. Charts might look a little blurred, but so these are some of the SPC charts, so looking at some of the data over time. So given that you've had a patient murder another patient on a psychiatric ward, there's some pretty horrific things taking place. So what are the things that they could change to help improve that? And some of these charts at the top show changes that they've made that are then showing the data that's saying actually the time it takes to, stay back on the cross, to identify one of these patients, refer them, get them a care plan in place and get some treatment taking place. If we can shorten that time, then hopefully the instances like this won't happen. And so they've made on a couple of the wards 66% reduction in the time it takes to get someone's care plan in place, 56% on another one of the wards. They're making real inroads to improving the way that they deliver some of these services. And importantly, these sorts of charts allow them to plot, right, at this point in time on this month, we made a change, and then visualise, you know, did things get better? Did things get worse? If they got better, did they get statistically significantly better? And if so, how do we do more of that? Or if it didn't, okay, what do we need to do slightly differently next time? Run another PDSA cycle. And then you start to work on this ward, so you take it to the next ward, and then you take it to the next ward, and you scale it up like that. And off the back of things like that, you then look at, okay, the number of incidents of physical violence taking place on some of these wards. They've been able to reduce that by 24% on one ward and 84% on another ward. Now clearly, still room for improvement. There are still horrific violent incidents taking place. It's not uncommon on some of the mental health hospitals, but they've been able to make significant improvements and do that at scale. They're doing that across a large mental health trust in London by adopting this kind of methodology and using this sort of platform to orchestrate the portfolio of work that they're doing. So that was just, if you like, a mini case study of that mental health trust here in London. As I said, the initiative started out here in the southwest and has spread across England. It's been going for about 2 years. So now there are, in the UK, there are about 450 NHS organisations using the platform, mainly in England, but also spreading up into sort of Scotland, Northern Ireland, and we're desperately trying to break into Wales at the moment. And that's, here in the UK, it's about 1,500 active improvement projects. And all these organisations in the UK can see each other's projects and see each other's data. There is an element where you can lock down, because some of the sensitivity of some of the data can be kind of constrained within your organisation. But fundamentally, we're trying to create an open platform that all these organisations can use together and learn and share from. And because it seems to have worked well in the UK, adoption has also begun to spread internationally. So it's now in use in 24 countries around the world. The UK is by far the most mature in terms of its user base and number of projects, etc. But we're seeing significant growth in the areas of, like, New Zealand has a very similar health system. Parts of the US are very different, but also there's a lot of significant healthcare challenges over there, and this methodology is well used over there. So we're starting to see it used a lot more by not just the hospitals, but some of the organisations that help facilitate and coordinate, consult with hospitals over in the US, and a whole range of different countries sort of in between. And this is, as well as it being a good news story, like, it seems to be successful, people like using it, it's being used in lots of different countries. The key thing for us about this spread is that what we're trying to build towards is this integrated global knowledge base. So you don't just see the GP practices up the road or in Newcastle, but actually what are the primary care practices in New Zealand doing? Because most healthcare systems around the world are dealing with very similar issues. We know that in New Zealand they're running initiatives around sepsis, acute kidney injury. There are national initiatives here on sepsis and acute kidney injury. We're tackling very similar issues. And every context is different, but there's always things that you can take and learn from others. What did they try and that worked? What did they try and didn't work? Would it work here? How different is our context? And only by building the sort of presence in all these different parts of the world are we going to be able to do that. That presents us with some significant challenges, because not from a technology perspective, having them all using sort of the same system is relatively straightforward, but it's more around the information governance, the willing to share data, kind of flies in the face of what we're trying to create, which is open collaborative platforms. There are some significant challenges around how you connect up global health systems, but that's what we're trying to aim towards. And even within the UK, a couple of the examples that I'd like to draw out. So the South of England Mental Health Collaborative, you've got 15 mental health trusts across the whole of the South of England, all working together on a big programme of work. There are 5 work streams, there are about 50 projects taking place. They're all using the system, they can all collaborate on the same projects, they can all share data, see the tests of change that have been done over in Southampton, try and apply that to ExIST. And they quite openly talk about stealing shamelessly. That is a big thing. You know, if someone else has done it and it worked, why am I going to reinvent the wheel? Why would I not try doing that? I'll have to adapt it for my hospital and, you know, the wards that I work in. But why try something different if it's been shown to work over there? So by bringing them together into one space, they're able to do that, and they're able to see that not just, you know, did it look like it worked? Actually, no, the data's there that it shows that it worked, and it's of statistical significance. So stealing those ideas is what we're essentially trying to support. And so that's a mental health example from across the south of England. You've got the Institute for Healthcare Improvement, who are based over in the US, but they do a lot of consultancy all around the world. We're working with them up in Scotland, so they're facilitating a programme with the Scottish Government and all 21 Scottish councils around children and young persons improvement initiatives. So this is all to do with like literacy, adoption, to do with children who have got family members in prison. How can you improve their health and well-being in all these different sort of situations? Obviously the councils are spread out across Scotland, and the IHI are based in Boston, Massachusetts, so they're not all connected, they're never in the same room, but if they're all using the same system, they can all see what each other's up to. They can see that, oh look, they've added some more data from the chart yesterday, is it working? The guys over at the IHI in America can help them out, get discussions going on the system, all of this sort of stuff. It all moves a lot quicker when everyone's looking at the same data set and able to connect each other up. And then the HSN network is probably the last one to talk about. I said this kind of started here in the southwest with the Southwest AHSN. There are 15 AHSNs across England, all broadly doing similar things, working with health and social care organisations. And they've been tasked by NHS England a range of different programmes that they're running nationally, one of which is a patient safety collaborative. So there are 15 of these collaboratives across England. They're all using the system, they're all running things around sepsis and AKI, they're all able to collaborate together, single programmes. They'll not just help the people running the individual projects, but you've got NHS England who are paying out millions of pounds to run these collaboratives. Are they working? Are we seeing any improvement? They're able to group all those together, run programmes in the system, and then actually see at an NHS England level, at a national level, is this working? Are we getting better at sepsis, to put it crudely? And there's just a few other organisations from different parts of the world, New Zealand, Australia, who are able to do very much the same thing. And as I said before, it works at different scales, and only by bringing everyone together using the same system that we're going to really sort of support this global knowledge base where others can steal great ideas from anywhere in the world, basically, to improve their local context and their local health system. So we've been going about 2 years, done very well here in the UK. It seems to have really be helping, and hopefully the London example was a good sort of demonstration of that. The focus at the moment is far more towards the international spread and growing the number of organisations in different healthcare systems, particularly trying to get into healthcare systems that are really quite different to the UK. So New Zealand is different, but in many respects is quite similar. The US is quite different. Some of the African countries are very different. Asia, it's different. So the more we can kind of bring them together into the same pot, if you like, the more that it's going to be beneficial. So trying to move towards this sort of global community of people working to improve healthcare, global sort of pot of improvement projects, success stories, failures that others can learn from. And by doing that, you know, the overall aim is that people can learn quicker, improve faster, and improve the quality and cost effectiveness of the care that's being delivered to improve the overall health and well-being of communities around the world, which is something we're pretty excited about. I think that's it.
Thank you. So, some questions for Jason.
Really enjoyed the presentation.
Okay.
I'm John Price from Throughout Creative Studio. We're a creative agency in Exeter. We work with the Southwest AHSN, and we work with a number of other clients in the medical sector, as well as a really broad range of clients. But I've seen a number of these systems before, mainly for things like e-prescribing. I haven't seen this before, and I think it's it's really a collaborative aspect. Something that's really important, really worthy, and I think something that's been missing from my experience of the way organisations work. I was just wondering, what if there's sort of a mediating body in the middle, in terms of if somebody comes up with an idea that they want to try on, if the system allows anyone, even a GP, to make some changes and to post them, who's sort of arbitrating what should or shouldn't be done to sort of break from code and try something that might be a little bit more radical?
Essentially, it's up to each individual organisation to do that the way they want to do it, and to run it within their own sort of local business processes governance. So there are some organisations where people can, if you like, say, I've got an idea, I want to start a project around this, and there's then what is partially an online but partially an offline process where they go through and kind of vet, does that meet our strategic priorities, if so how, and making sure they've got a team together to support that, and only at that point do they get the sort of go, no-go decision. Particularly if they operate at large scale, organisations have a lot of process around how they do that. So you don't just get people sort of firing off in all directions trying to change things. But other organisations, it's far more fluid. The GP practice, for example, they don't need that level of governance and orchestration. It's far smaller. If someone's got a good idea, they try it, that sort of thing. So it varies across the patch, and it kind of depends on the maturity of the improvement sort of practice in place within those organisations. But there is no single overarching vetting at a national level, no. I mean, you've got the likes of NHS Improvement who say, I think these are some of the key big ticket items that we need to work on, like sepsis, like AKI. But there's no one saying, okay, you've got a good idea for how to deal with acute kidney injury. No, that's, we don't like that idea. It's more a case of, okay, you go try it. These guys are trying something else. If that works, then there's a level of coordination, but there isn't really that control or vetting at a national level.
What's the sorry, it's Piers Cotting from UCL in London. I'm an incomer, explain story. But what's the sort of adoption sort of cost, as it were? How easy is it to get up and running on this? You've talked about big organisations, you've talked about GP surgeries, so presumably the implementation cost and the starting to use it is as simple as turning it on, is it creating accounts and using it?
Yeah, well, it's a web platform that we host. We host with Amazon Web Services, so there's no coming around and people, dealing with IT departments and installing stuff locally. You go to the website, punch in your email address, sign up for an account. Yeah, and someone sort of locally within your organisation or whoever's holding essentially the subscription for you to use it would verify your account, and boom, you're in and you're away, and you can run as many projects as you want. An organisation can essentially have as many people as they want, assuming that they can afford to pay for that. And part of the reason that it spread so rapidly in England in particular is the 15 AHSN organisations have subscribed on behalf of their regions. So for all of the hospitals, it's free to use. So there's no financial upfront commitment there. So they're a bit like, okay, well, why wouldn't they? There's still that implementation cost of, okay, we need to get all of our staff using it, all the staff that are working on projects. We want you using this. This is the way we want you putting data in. But a bit like, as Colin mentioned earlier, it's got to be as intuitive as possible. It's kind of like the iPhone test. No one's ever been on a training course to use an iPhone, but you can do all sorts of things with it. From our perspective, the system has to be that simple. We don't run training courses. There is barely a user guide. If you needed a training course, we failed, basically. It does assume a certain level of understanding of the improvement methodology that we're using.
It's used by QI people.
Yeah, and we're not QI experts. We're the software people, basically. So it's used by people who are doing QI. And a lot of organisations, if they're then training people in QI, they've trained using the system, introduces the tools, and then they've got a system to go and run their projects when they leave the training course. So as far as possible, trying to keep that implementation costs as low as possible. Colin?
Richman from ExIST. One question, when I've seen sort of methodologies used in sort of trials, there's obviously an impact sometimes that happens because you are doing a trial, you're spending more time with the patient, therefore the outcomes are better. Do you ever see type of artifacts coming out in the data?
Yes, and that's why they move through a few phases, a lot of these projects, or even individual changes that you make within a project. First of all, you've got to spend a decent period of time gathering your baseline data. So what does normal look like? And normally what people are keen to do is start making changes before they've got enough data behind them to say, I really understand what normal is for this process or this activity. So they've got to do that for long enough. Then they spend a period of time testing something, and hopefully they come out of that with, okay, we think this is the change, or these are the key changes that will lead to an improvement. It's then about making sure you continue to measure beyond that. So if you've made some improvements, it's a lot about sustaining the gains. How do we make sure that this improvement that we've seen doesn't fade away? Or how do we take it from this ward and move it to another ward, and what do we need to do differently there? So it's, yeah, the danger is, we think we've got the answer, and then you kind of take your attention away from it. And if you don't sustain the gains, if you don't work hard to implement the change that you've identified, then you can end up back where you started.
Well, Jason, thank you very much. That's really quite insightful, and actually from anybody that's ever used a CRM package in your work, you know actually how difficult it is to get people to use a piece of software intelligently. In fact, you've had such growth, I think, is testament to the fact that it is a very easy and accessible platform.
Thank you.
Jason, thank you. So, you've seen now how you can take a journey from getting some very profound information as to the performance of an organisation, and then starting to engineer how you can start to make changes in that organisation and involve the right people in the decision making. Extrapolate that a bit further. So imagine that we need to also be not just talking to those who are expert practitioners, but we need to be talking to the patients and their carers and those who are informing the research. How do you pull all of that together into a platform, into an initiative? And we're lucky to have Piers Cotting, and don't mention public transport to Piers, because I think he arrived home after train problems from Paddington yesterday at 2 o'clock in the morning. I saw your email arrive. I wasn't up at 2 o'clock in the morning, but Piers most certainly was. And Piers, as a project manager for Joint Dementia Research, and in a sense as a little bit of a technology entrepreneur, and now with the University of Exeter, I gather, yes indeed, will tell you about not just Joint Dementia Research, but wider best practice in this field. Piers, over to you. I'm just seeing whether I've managed to break it again. It's thinking.
It is thinking.
It's thinking. Bing. There we go.
Thanks, Robin. Thank you very much for having me, even if it took a bit of a mammoth journey to get down here. But so I'm Piers Cotting. I currently work at UCL in London. My day job is as Programme Director for Dementia Research at the National Institute for Health Research. So I'm looking after the government's programme of research in dementia across sort of the whole range from what they fund to how we deliver it. But I'm also just about to, in September, move down to Exeter, so I'll tell you more about that at the end of this presentation and why I'm doing that. A shameless plug just quickly at the beginning, because I think it's still recruiting. I'm a fellow of the NHS Innovation Accelerator programme, which I think has got an open call at the moment for SMEs who have market-ready health innovation that they want to take in and do what Seedata have done so brilliantly, spread through the NHS quickly. It's sponsored by the HSN network. So if any of you are representing or know people who've got sort of market-ready, sort of already tested, sort of piloted health technology innovations that they want to spread quickly, it's a really good programme to help do that. So by way of, just check the cross, so by way of overview of what I'm going to talk about, what I'm going to describe is some work I've been involved in over the last 3 or 4 years. That's all been about how we deliver clinical research in the NHS. And what we've been looking at is how you, as Robin said, how we take a population and get them more aware of research, get them engaged in research so that we can then access people and their data in order to be able to screen them so we've got the right person for the right research project at the right time, and in doing so make the research quicker, cheaper, and more sort of equitable in terms of where you can access research from. So you don't have to be sat next to one of those teaching hospitals with the dot at the bottom left that we saw earlier. I'm going to do this by first of all describing what we've done in dementia. I'll describe the impact that's had. That's probably of limited, specific interest, but I will then describe what we plan to do in terms of generalising that, in terms of internationalising the dementia product, very much in the way that Seedata have done in terms of creating a sort of collaboration globally around quality improvement. We want to create a global collaboration around dementia research. But then probably most interesting, I think, to us here is why I'm moving to Exeter and what we want to do in terms of taking some of the learning and the approach and matching it to what's already going on down here to have a really big impact on the local environment and how we do health innovation. So where did we come from? This is now going to talk about the sort of the dementia piece of this work. And Robin said at the beginning that it's the NHS is a nightmare to work in. I don't know quite what you said, but it's difficult to affect change in the NHS. And he's absolutely right. And these data sort of show that. So my 10 years ago, my responsibility was to take quite a sizable investment from the government and improve the way we delivered dementia research in the UK. And you'll see from these data that to begin with, we had quite an impact, as in we took money, we thought about how the system works, we tried to change the way the NHS system worked for research. And you'll see in the green bars, this is growth in the number of people we were recruiting to studies. The blue line is the number of studies that the dementia research community were successful in getting funded. And we had good growth over those early years. The systems we did put in place to help the researchers get more funding and develop more research, given that we were also seeing increasing investment from the government in that research, continued to grow. That's the blue line. But we got to a point where we... before we get to that point, so we also saw improvement in the performance of those studies. So not just growth in the capacity, the number of studies, the number of people, but moving from a point of view back in 2005 where it was very few studies did what they said they were going to do. And industry was leaving the UK in droves in terms of this is a difficult place to do research, to the point 5-6 years later where most studies achieve what they said they were going to achieve. So big impact, big investment, big impact. But we got to the point where around 2010-11, where we'd reached a peak. We'd tried to improve the NHS as much as we could, and it started to get to the point where we'd reached that's our limit in terms of continuing to improve the current system. And at that time, these data from a couple of years later, we knew we'd failed when we saw these data. So these are from a partner of ours, one of the big charities, Alzheimer's Research UK. So we'd spent years and years and a lot of money trying to make dementia research just on everybody's agenda. And yet we found from these data, which is a survey of people over 55, not people with dementia, just a general population, that people wanted to be involved in research. People are scared of dementia. It's I think, the second most feared disease in adults over 55 after cancer. But no one knew how to. So there was a real insight to us that actually we'd failed over 5 years of sustained work to try and achieve much higher than 19%. So we changed about 3 or 4 years ago, that insight came, and we thought to ourselves, well, we're trying to change a system that's difficult to change, and actually we now know that lots of people are interested in this, in being involved. So let's actually just think about the people. Let's just think about the public, the population, and how we can engage those people in helping us do what we want to do, instead of trying to improve the way medics do things at the ground level. And so we've worked very hard with, or very much in a collaboration with the main charities in the area and people affected by dementia. So this has very much been a sort of, it only exists actually because of some of the people on the top, not me, but some of the other people on the top of this, who are people affected by dementia, saying you won't succeed if you keep doing what you're doing. And it took them a couple of years of saying this before we actually listened, which I think is interesting learning from a public sector perspective. So that's the background. What is it? And I should put this up because so the gentleman asked a question about from a design perspective. You can see we're ready to come to you as a client to refresh our design. What is it? It's essentially an internet dating site for research. It's as simple as that at the moment. So it's match.com. We promote research. We promote the fact we have a database of patients to researchers. We promote research to the public. We take data from both. We use very simple matching algorithms to match those data, and then make the introduction of those people directly, so researcher directly to patient. So essentially, in a sense, it sits outside the health sector. It's promoted very broadly. It's very much a collaboration in the public sector. It's promoted by all the main charities, by the NHS. 80% of NHS memory clinics promote and support recruitment to it. It's not easy. I'm sure all of you who work in the sort of public and consumer marketing space, it's a very contested. Even if you think you've got a good idea, it's expensive and contested gaining traction and acquisition of customers. It's no different in this space, I don't think, than any other. People get into it online, by telephone, by postal application, all sorts of things you'd imagine. 70% online. So it's essentially that. It is essentially we make as much effort to tell people there's research going on as possible. We have a cloud-based platform that collates all these data, structured data about research, structured data about patients, and we make that accessible to researchers to use. So it is very simple. So where have we got to? It's going okay, I think is the truth. As in, it's growing well, although I think we'd have expected to see this be exponential or more exponential. So you'd think if you develop a good consumer platform, and it is actually good, that once you get thousands, tens of thousands of users, they begin to bring other users in and you see some exponential growth. Actually, what we're probably seeing is that we've done the easy bit and we've got people who are interested and they've joined, and now we've got to do the difficult bit of how you go and start finding people who are less interested, and that acquisition cost is more difficult. But it works in terms of people who are in the platform find this platform works for them, as in those people who wanted to be involved in research but didn't know how to now can. There's lots of data from I'm not going to show it from the people in the system in terms of, yes, we've changed the dialogue between the NHS and researchers in terms of how people can directly access them. Researchers who, if the NHS is difficult to change, my word, changing researchers is really difficult. These are difficult people, right? Researchers are difficult. That's why good researchers are really difficult. That's why they're good researchers. So we've been really pleased with the uptake in the research community. And I wave to my University of Exeter colleagues, but it's true. We've had good uptake in the research community, and so this has been going for a couple of years, and we've seen, this is 171 organisations across the country, universities, trusts, 800 researchers using the platform, 150 studies. This is more than we expected in terms of putting it out to the market and saying, use this system to change your practice. We did about, I think last year we were just over 20% of the total recruitment to the dementia portfolio came through this system. So that's 2 years, 20% market share, which was way above what we thought we would achieve. And then the impact has been, these data aren't showing all of the impact of this work. There's lots of other work being going on. But this is the same graph I showed at the beginning. We'd reached that plateau, and then we've put something new into the system alongside some other things. So very much, we can't claim all the credit for this. But we've seen now a greater growth, a greater ability to recruit people to those studies that have been on. So we're pretty sure it's working in terms of gaining access. Probably much more importantly for me, and actually some of these people are down here in the southwest, is what we've actually seen is people buying into it. So these are just people out doing cake bakes on Saturday mornings or charity runs to promote dementia research, which is sort of, this is not your field, but necessarily, if anyone's in this field, 10 years ago, the idea that people would have a cake bake for dementia research, the idea that they'd even have a cake bake for dementia, to be honest, 10 years ago. So the idea, for us, it's really important that people are beginning to buy into the fact that this is a condition that can be researched. And we think that's going to have a big impact in terms of the way people think about dementia, not just in terms of what we're able to do as researchers, but attitudes to a condition that 10 years ago was, hardly even talked about. And I said, with that sort of level of sort of evidence base, we've then had a sort of, I would say, a double-edged sword in that the government's adopted the platform as its sort of go-to. So in the dementia strategy to 2020, this has been adopted as every trust should use this system. There's a target for it. Double-edged sword in the sense that when you demonstrate something initially, EU, we all probably do this commercially as well as non-commercially. You know, the temptation is to talk about the good things and to be glossy about what's worked. And the temptation in government, of course, is to take things they think can be done easily and they can demonstrate impact easily and ask for them to be done more. It's not going to be easy to take from where we've got to what the government wants us to achieve. So I think it is a bit of a double-edged sword. So what's next? Well, along the way, we took all the learning from those first couple of years of putting a sort of minimum viable product out into the market, 28,000 people using that in terms of volunteers, 800 research users, lots of studies. So there's a lot of learning you can imagine coming back from that in terms of how do we make this better. So we funded by the Small Business Research Initiative for Healthcare, which if any of you have not, again, if you're in the sort of SME world and have not come across the Small Business Research Initiative for Healthcare, it's an Innovate UK source, which is fantastic. It invests up to £1 million in your company with no returns coming back to the SBRI. So if you have a health innovation you want to take to market and want up to £1 million worth of capital invested with an investor who doesn't want a commercial return, go to the SBRI. They're fabulous. So they've invested in the creation of a platform that can do so much more than we've done, that is built in a way that can start talking to some, for example, some of the other initiatives that we've heard about today or we're going to hear about in the last talk. So much more thinking in terms of connectivity to other systems. We've built a connection into one NHS electronic health record so that you can just push a button and populate our data, those sorts of advances that make this much, much more powerful. That platform is now sort of sat and finished with a test implementation, and with everything that's going on in government, we don't yet have a decision to implement it for joint dementia research in the UK. So our market sort of plan for that, and this is currently a public sector project, as it were. So this is owned by UCL Partners, one of the academic health science networks that has adopted the QI platform. And UCL, and soon the University of Exeter. The plan, of course, is to continue to negotiate with the government to move the joint dementia research work across onto this much more impressive platform. But the opportunity, of course, for us while that's going on is we've got a great platform, we've got a great exemplar of how this can work in one disease in one country. So we're having some fantastic conversations with other countries. I think there's significant adoption and internationalisation, commercialisation opportunities to do this in dementia in other countries. There's the World Health Organization have just adopted dementia plan. So there's every country signed up to the WHO has a certain set of outcomes to deliver. So there's some real drivers for doing this internationally, and there's a real pull from countries around the world. Which is good for air miles, but not good for family life. What we really want to do, though, I guess, is say that's, from our perspective as dementia researchers, people really interested in dementia, but this is completely generalisable. There's nothing that we're doing here that is in any way specific to dementia. This is consumer marketing to people. Tell us a few bits of data about yourself. Make those data available to researchers. It's very, very simple. When we started, I should say, I haven't lost track of the time, but our assumption was the more data, and this I think in this context is probably quite a helpful discussion, was that the more data you have, the better, right? Big data, get data, data's great, you can do lots of data. As it turns out, the graph doesn't look like that at all. So you need a very small number of items of data to do the job we're doing. And just who are you interested in, and do we know enough about you that we can at least take out the big part of that funnel, that whole population down to someone we want to talk to about our research. You don't need to get down to the nth degree. You don't need all the data. And getting a lot of data clearly is at a patient identifiable level is extremely complex from a governance perspective. From a governance perspective alone, I mean, there's lots of other issues around it. So this isn't necessarily big data at all, but it doesn't mean, for example, it's not data that could be applied to machine learning. So we have nurses screening people on the telephone. We're now thinking about how could we have train a machine to be listening to those conversations and learning from those conversations, data that those nurses can't necessarily filter and pick out, and use AI in those sorts of ways to improve screening. But it's not big data necessarily. Sorry, that was a diversion. But I'm going to finish by saying, so all that's fine in the sense that I think we've got something that isn't magic, right? It's not, I'm going to be really clear here. We haven't developed a cure for cancer. We haven't developed some really exciting algorithms that we've got patents out on. What we've done is we've said we have a bunch of knowledge about how to do a process, recruitment to trials, and we've explored how to turn that into a consumer marketing approach, and we've learned from that. But along the way, both at UCL and here in Exeter, the sort of insight has been, well, that's all fine. We can do that for one population in one type of disease area, but why not do it at a population level? And why do it for clinical research? So essentially all we're saying to people is, do you want to be involved in, at this stage, clinical research? But the conversation isn't about clinical research. If you talk to people who have a diagnosis of Alzheimer's, the conversation is about standing up for themselves, tackling the disease, doing something in the face of treatments that aren't available for them, making a difference for their future, for their families, those sorts of things. So that's not just about clinical research. So we really think that we can do something really special down here. We think the population down in Devon is really interesting, some really nice mixes between urban centres and very rural centres. There's a nice spread of population from that perspective. So why don't we take this approach and say, can we turn our entire community into a group of activated, engaged citizens who believe in changing their and our future's health through research and innovation? Not everyone will come on board with that, but you don't need everyone to come on board. To make a real difference to both the university and NHS researchers, and more importantly here, to entrepreneurs and small businesses, you need to begin to get enough of your community here to be putting their hands up and saying, I want to be involved. I want to be, if you've got a new health gadget, test it on me. I'll be an early adopter. And all of us involved in this know that's really difficult. To find those early adopters is difficult. They're out there. We just need to ask them to put their hands up and take simple amounts of data from them and start from that point. So I'm coming down in September. I've been offered a job down next to work with, there's a number of initiatives. This is not the only initiative at all. There's lots of work going on across Exeter in this space, in the medical school and the university. And then to start working across, as is already happening, all the amazing sort of support systems that are in place for incubation. So the idea here is, can we use a little bit of insight in terms of how to engage our community and turn them into something you can access? If you want to change things that you'll be able to access. And we think that will be hugely powerful. I mean, as in, I'm involved with the NHS, the London Digital Health London. I can't remember what it's called now, the accelerator, Digital Health London Accelerator. And they have to contend with a hugely complex environment in London. I mean, just London. In terms of the number of CCGs, the number of trusts, the number of mental health trusts, the number of quangos that are based there, the number of organisations. I think we've got an opportunity here in the public sector, in the sense that it's more tractable. There's fewer of all those organisations. You have to get 10 or 15 people in a room to really start thinking about how the public sector does all this stuff, and you're already doing it. And I think we've got a population that's going to be really valuable to, and really, valuable to health innovation and health research. So that's the plan. I don't know how long it will take, and when it will be when you'll see the benefit of it. But this is all about, I guess, taking the learning and bringing it back down and saying, let's do something more impressive, more locally valuable. Thank you.
So there's, oh my goodness, there's even some contact details if you want to talk. And we've certainly heard this at a range of ExIST events in the past where we have an elderly and rapidly dementing population as being seen as one of the significant challenges in the southwest in particular. I think we're something like 10 or 15 years ahead of the national curve. So when people want to think about what is going to happen nationally with an elderly and dementing population, they will come down to the southwest potentially and take a look around, not just for Sidner, but obviously there's a whole range of other parts of the country that you might go to. But any questions for Piers? I shouldn't mention Sidner. You're all from Sidner.
Still Sydney.
This technology, this platform, is applicable for many other things, isn't it? So, I mean, any disease.
Yeah,
Potentially.
yeah.
You could use something like this to recruit those who are passionate about trying to cure that disease because they've got a loved one with it, or they themselves are likely to suffer from it. And it's connecting them with research organisations, be it in the public or private sector, but obviously with a public sector hospital behind it, to enable them to undertake those research trials.
Yeah, but I would think of it more broadly than research. I mean, as in the NHS Innovation Accelerator Fellowship, you know, those are mostly, you know, small startups, little health tech things, you know, widgets, gadgets, apps. So there is obviously research with a big R, you know, university-driven and academic research, but there's also market research and there's also prototyping. There's lots of ways I think we should be much more. We should be much more ambitious about how we ask our population to engage in changing their health outcomes.
I mean, it's more than just a broadcast. That's a reciprocal.
Absolutely, yeah. So it's a conversation and a reciprocal relationship. Yeah, absolutely.
I'm quite interested in the point about used to be slightly disappointed about the curve not being quite as steep as you'd hoped in the last year or so. And I'm wondering, I mean, as opposed to something like that in Facebook, where it's a socially external, everyone wants to show how happy they are and what fantastic things they're doing. Is there something slightly private and sort of internalised about the reasons why people are volunteering for these types of programs, which possibly they're delighted to get involved in individually, but they wouldn't necessarily want to tell anyone else about?
Yeah, that's definitely true. And we see that from the conversation we have with the people signing up. And things like, for example, people would sign up. They may sign up themselves as a volunteer. Let's say I'm caring for my mother. I may sign up myself, but I may not talk to my mother about doing it. Or I might think that's good. I'll encourage other people to sign up, but I won't sign up for myself. All of those behaviours happen. Yeah.
Paul, sorry.
People you're trying, sorry, Paul Shepherd of ExIST. Piers, the people you're trying to get to sign up for a particular cohort, is this an age group with a predisposition, as far as dementia is concerned, is this an age group with a predisposition to dementia you're after? Are these people already suffering from early stage?
No, it's anyone over 18 actually in our platform, which is why one of the reasons that we think the approach is sort of really applicable to, you know, doing something on a population level. So there are a number of initiatives that focus on particular cohorts, and we're thinking about launching something separate branding, looking at a particularly high-risk group, because there's some significant ethical issues. But this platform is very much open to everyone who's over 18. What the demographic is, I didn't go into this detail, but it's quite interesting. There's only 15% of the total people signed up have dementia. Another 15 are sort of peri-diagnosis, so that's about 30%. The big chunk, about 40%, are people who are sort of 55 to 75 who don't have any symptoms. I wouldn't necessarily say there are healthy controls, so some of those people will have underlying disease, it's just non-pre-symptomatic. Some of those people will be, you know, high risk, and some of those people will be classic sort of healthy controls. And they're a really interesting population. So we've just done a pilot with a pharmaceutical company, a big trial that's going on at the moment in the prodromal space. How do you identify people with preclinical or, you know, very early clinical disease? And that's and we've obviously got sort of an enriched population in here to be able to try and identify. But it's very. I agree, but yeah. But there's a lot of interesting ethical issues, which comes back to, I think, the point about what are people's attitudes to being involved in this sort of thing. And I think where we've not been sophisticated enough, and where the new platform, and when we now implement this elsewhere, one of the things we're really wanting to do is it has to become more of a conversation, more of an attitude change. And if you think about the way things like Facebook and those sorts of companies grow, they very much understood that, you know, they from a data perspective as well as a sort of consumer marketing perspective, and we haven't at the moment. We've just scratched the surface, I think.
Thank you. Last question.
I wanted to pick up on this point about what the exponential. It's not dissimilar to VCs assuming that the product's going to go on the hockey stick. It really doesn't work like that. And it isn't about people being homogeneous and just having more or less disposition to take up. We know a lot about this. I mean, there's a diffusion that's been well understood for decades. We've got different cohorts with different criteria for adoption, communication between them, different issues. Maybe we can talk about this.
Yeah, it'd be really interesting because I just think we haven't applied that science to how we might achieve this. Yeah.
That's excellent. Well,
thank you, Robert.
so much, and thank you for making. Do you know, you did the perfect drum roll for our next presenter because you talked about getting an excellent academic and how difficult they are. Actually, it's been really easy to get Professor John Terry in the room. John, actually, what John can help us with is actually how you can start taking some of this research element and starting to, see and apply it and to make decisions, and even to the point of potential commercialisation of it, in a sense, taking it out and turning it into a viable entity. So, without any more, it's thinking again. It's thinking. I think if I step away from it, it might actually go straight forward.
Okay. Just wanted to check. We do have sound in this setup. We do. Brilliant.
Right.
Just because we've got a movie.
It's
so
just
that's
a
good.
little bar that's going round and round and round as we speak.
Okay, well, while we wait, I just want to say good morning, everybody, and
Thank
thanks for the opportunity to speak here. So, in fact, I've been in 2 talks in the last 2 days, one of which I was told that mathematicians were weird, and today we're being told that researchers are difficult. So, as a mathematics researcher, this may be a little bit awkward in the next few minutes, but hopefully not. So I just want to really talk to you a little bit about some of the research we're up to at the University of Exeter, and I want to give you a case study in a particular example of how we've taken fundamental research and we've begun the journey towards translation of that research into something that we hope will benefit people with a debilitating neurological condition. So, what we're calling Maths for Health at the University of Exeter, we've got a number of initiatives going, and the one that's of particular relevance to the audience today has been funded a year or so back by the Engineering and Physical Sciences Research Council, and it's called the Centre for Predictive Modelling in Healthcare. And the idea behind the centre is essentially to bring a cohort of mathematicians, statisticians, computer scientists together with researchers in the biomedical and clinical space to begin to think about how we can fundamentally advance our understanding of the causes of disease, and how can we then translate those into practical tools and devices that could advance clinical understanding and ultimately lead to patient benefit. So we're thinking a lot about neurological conditions in particular, and the reason we're doing this is because many neurological conditions, the diagnosis either comes too late. So, for example, in dementia, by the time you're showing signs of memory loss, basically all the treatments we currently have are likely to be ineffective. So is there a way that we could actually probe data that we routinely acquire in such a way that we could actually make a prediction at an early stage, before people are symptomatic, and start treating accordingly? Similarly, in the example I'll give you in terms of our work in epilepsy. So epilepsy is a condition that is characterised by the tendency to have seizures. And the trouble with seizures is that they're unpredictable and they don't occur on cue, by and large. So you go into clinic, you've been experiencing some funny turns, and we want to find out if you have epilepsy, and what we're trying to do is observe you having seizures. But of course they don't happen on cue, so actually there can be a large waiting time prior to actually observing a seizure in an environment that a clinician is happy with, and then saying, okay, this is someone with epilepsy. So again, is it possible to actually interrogate this data that's routinely acquired and find evidence or markers that someone actually has the condition without necessarily observing the symptoms? And as I mentioned, it's really important that we partner with clinicians and industry to try and translate this fundamental research into what we might term decision support tools. So I think what I'm going to do now is just actually play our movie, which just gives you a bit of an introduction to some of the work in epilepsy, but from the perspective of some of the key stakeholders.
suspected of having epilepsy. My diagnosis was really quite quick. I saw the specialist, I had an EEG, and my EEG told me straight away that I had epilepsy. And since then, I then received treatment. My daughter's 8 years old, and she's going through a different process. It's not been smooth at all. So she's seen the specialist, we've had an EEG, but the EEG's been inconclusive. So right now she hasn't been diagnosed. She's having seizures at different times, but she doesn't have a diagnosis, so we don't have the treatment.
For 150,000 people, like Al's daughter, the EEG is inconclusive. For them, the journey down an uncertain pathway has only just begun. The time to diagnosis might be their next visit to clinic, after being monitored for a week at home, or not at all. It depends on whether something happens.
I had twins in 1984. At 19, the girl Jo, she developed epilepsy.
So I think we're going to have to just call that to an end. Something seems to have gone wrong with the timing of the movie relative to the speech. So listen, I'm going to have to just explain in words what the real challenge is. So sorry about that. We'll try and sort out the technical difficulties for next time. So essentially at the moment we have this scenario where if people come to clinic, typically they're referred by their GP, they've gone to the GP and they've said, I'm having these strange events, and often parents will say yes, the child, if it is a child or adolescent, has had particular events that just don't seem to be quite right. So they'll get referred on to a clinic, and in some cases a case study, a clinical case study will actually reveal, okay, this is someone with epilepsy, but typically what happens is that we hook them up to an EEG machine and we perform this EEG. So what it does is it measures the aggregated electrical activity of neurons in the brain. And what we're looking for is a marker in the EEG that correlates with seizures. And that marker is essentially synchronous activity. So what happens at the moment here, this is just background EEG. So this is what it looks like just in most subjects without epilepsy who are just sitting there quietly, and also in most subjects with epilepsy who are just there sitting quietly. Looks pretty meaningless from a dynamic perspective, just seems to be a noisy signal going along. But during seizures, this signal changes dramatically, and you don't need to be a neurologist, really, to observe that difference, because it's really marked. It's huge spikes and slow waves, so it's basically an oscillation that's very rhythmic, very observable, and very repeatable across people with epilepsy, hence why it's currently the main marker. But the problem is that, as we mentioned here, that across the US and Europe, 350,000 people annually will have an EEG where all we see is this. Can't tell, it just looks like a healthy subject would look. So is this someone with epilepsy or not? And hence, the time to diagnosis for most people with epilepsy is between 9 and 12 months after that first visit to clinic. And the reason is that we have to bring them back, we have to monitor them for longer, we have to do things that we believe might make seizures more likely to occur, such as sleep depriving them, exposing them to flashing lights, asking them to hyperventilate, all hoping to observe seizures. And as a result, misdiagnosis is common, both telling people that actually have epilepsy, you don't have epilepsy, but conversely telling people that don't have epilepsy, that they do have epilepsy. And the estimated costs of misdiagnosis are significant. So in the US, they're estimated at between 1 and 4 billion. And in the UK, back in 2011, there was a joint parliamentary party group report that put the costs of misdiagnosis of epilepsy to the UK of £235 million annually. So that's both in terms of not only prescribing or misprescribing drugs, but also the effects on productivity. So many people with a diagnosis of epilepsy feel unable to work. They're in fact told they can't drive, they can't operate heavy machinery, etc. So it has a real consequence. So the best sort of current things we can do, as I mentioned, is to essentially send people away, hook them up to one of these devices that maybe, I can't really see it in this picture here, sorry, it could just be an actual cap like this, or it could be a device which is actually wireless, and we ask them to go about their business for a few days, a week, 10 days, etc., alongside video recording in the home, and then what we're doing is hoping to observe seizures, marry them up with markers in the EEG, and confirm the diagnosis. Now that has some advantages. It's certain, right? So we're pretty certain, and I say pretty certain because actually there are about 1 in 40 of us who will display abnormalities in the EEG that look like seizures, even though we don't actually have epilepsy. So basically we would be displaying EEG abnormalities even though I was, say, talking to you like this normally. So it's not a perfect marker by any stretch of the imagination, but it's the best we have. But there are lots of disadvantages from the patient perspective, and some of those were discussed in the movie, but I'll just outline them again here. These devices, really impractical. You know, you don't want a load of wires sticking out of a cap that you have to carry around with a box attached to your waist if you're lucky, or if you're unlucky and in one of the trusts which have the older devices, basically carrying a large box around with you for a long period of time. And it's invasive as a result. It's obviously expensive and time consuming. It delays treatment because until we see these seizures, we're not treating you. There's a lot of stigma associated with it. Bullying is listed as a common issue for people with epilepsy when they're being monitored, people going, what on earth's that on their head, etc. And it exposes these people to risk because the most likely indicator of your tendency to have another seizure is how many seizures you've had up to that point. So every day we're delaying treatment for someone with epilepsy is a real issue. So what's our solution? Well, we've termed it BioEp, and basically it came out of research that was undertaken with a colleague of mine, Professor Waldman, who's in the audience at the back. And we had this idea that rather than just waiting for seizures to happen, there must actually be something about the brain, and in particular the way different regions of the brain were connected in people with epilepsy, that were slightly different to normal controls, such that the likelihood of having seizures was elevated in those people. So what we did is we took a cohort of people with a particular category of epilepsies, and we also took a cohort of normal controls, but additionally we took a cohort of first-degree relatives of the people with epilepsy. So these were close relatives, but who didn't themselves have epilepsy. And we found some really interesting things. So when we looked at the way these networks were connected, we found particular patterns in those networks that were specific to not only the people with epilepsy, but also to their relatives who didn't themselves have epilepsy. So the Lancet Neurology, in their review of studies back in 2014, were really excited by this because actually it was the first demonstration there really was some kind of genetic basis that suggested a predisposition to epilepsy. Because it's important that we think at this point that by observing only these changes not only in people with epilepsy but also in their relatives, this isn't the sufficient condition, it's just a necessary condition for epilepsy. It's something in addition in these networks, and that's where the maths comes in. So what we do is we say, okay, we can take this understanding of altered networks, so we take the background EEG from a subject and we transform that into one of these networks. So basically what we've done here is use some statistical methods to say how are these different regions of the brain, as we measure them using EEG, interconnected, and we get a graph that looks a bit like this. So these are connections between the different EEG channels. Then what we do is we actually then put a computer model into this. So what on each of these regions, what we do is we say, okay, we have now a model that describes how the brain transitions from a healthy state to a seizure state. And then we use this computational model to then simulate this individual representation of the brain for as long as we want. So if you imagine in real life we've got to monitor someone for a week or 10 days or a month or a year before we see a seizure, we can do that simulation in a matter of seconds on a not very powerful computer. And like here, for example, we see that when we do simulate this particular network, we find after a short period of time a computational seizure. So we would say that this is someone who's actually likely to have epilepsy, even though we don't see any seizures actually in the data that we've collected. So in terms of our current progress on the research side of things, We've demonstrated, as I mentioned, not only in the case of idiopathic generalised epilepsies, but also in another class of epilepsies. There's two main classes of epilepsies, IgE and what are called focal epilepsies, and we found similar results in both cases. So what we've then been thinking about is how do we actually then translate this into something practical? And the talk we had just now from Piers, it's really, really important to involve all key stakeholders, particularly people with lived experience of disorders in the research. And let me tell you why. So when we started this, we spoke to a number of clinicians, a number of neurologists about this challenge. They all told diagnosis, pretty good at diagnosis. Prognosis, if you could tell us what drug to give and whether people will respond well, that would be fantastic. But diagnosis, you know, we're the experts. Speak pretty much to anyone who has been diagnosed with epilepsy or been through the pathway to diagnosis, they will tell you a very, very different story. They'll tell you that it was uncertain, they weren't really clear what was going on, there was a number of EEGs taken before you reached that point. So without that engagement with people with lived experience, you know, as researchers, if we just listened to clinicians, we'd probably gone and done some other research, you know, thought, well, that's not that important. Actually, it turned out to be really, really important. Particularly when we undertook the health economic assessment of the pathway in terms of how we would change this. So imagine at the moment we have all of these sequential EEGs up until the point at which we see a seizure. If you imagine with the current levels of sensitivity and specificity we're achieving, that at that first EEG, if you didn't see a seizure, we undertook this computational analysis and used this to make a diagnosis in conjunction with the rest of the information available. The health economic benefits are estimated at £625 per person put through the pathway. So each year there's around 100,000 people in the UK that would go through this pathway. So that's potentially quite a big saving. So we've taken this idea over to the US and we were a finalist in the Epilepsy Foundation's Shark Tank competition and we were awarded a $5,000 prize to help us on this journey towards commercialisation, where what we're looking to do, as I mentioned, is essentially provide a decision support tool for electrophysiologists and neurologists looking to diagnose epilepsy. So what are our next steps? So essentially, we've got to create the data architecture and infrastructure to actually enable us to provide this service. We need to create a clinically representative database. So the numbers I presented to you earlier look impressive, but there is a big caveat, and that is that, of course, what we've shown to date is a comparison of people with the condition versus the clearly well. Okay, now, of course, people who clinicians will meet are those who are not necessarily clearly well. They have displayed symptoms that could be epilepsy, but turn out not to be. So at the moment we're in the process of establishing what we would term a clinically representative database. So these are people who have come to first seizure EEGs but ended up, often after years, being given a different diagnosis. So there's various other conditions that can give rise to similar symptoms to epilepsy. So things like syncope, which is a cardiac-related condition, or what are termed psychogenic non-epileptic seizures, which is basically where an individual actually, well, it's essentially fakes a seizure, inverted commas, even though they may not consciously themselves be aware that they're faking it. So anecdotally, clinicians will tell you that if anyone has a seizure whilst waiting to go into the EEG monitoring, there'll be someone with psychogenic non-epileptic seizures. It's not quite as clear-cut as that, but you know, this is the sort of thing that these seizures tend to happen on cue and in situations where you might be expected to have a seizure, if that makes sense. But again, very difficult to formally diagnose. Wes has recently been awarded a fellowship from the Medical Research Council to develop that angle of it, to actually understand, you know, how well these methods delineate between people with epilepsy and people with symptoms that look like epilepsy but don't, and it's looking pretty promising. We also need to develop the prototype software as a service and perform a clinical trial which actually demonstrates the value of this as a diagnostic tool, i.e. what time to diagnosis is saved as a result of using this research. We also need to
achieved regulatory approval, CE marking, FDA 510K, and then ultimately launched a product. So that's really where we're at the moment. We're looking to actually incorporate Neurognostics later on this summer in the next few weeks, and then begin this exciting, or continue this exciting journey. Here's just an example of what we've basically achieved so far. So if you imagine we have this seizure marker, if you like, and we can scale it between one value and another, you see that people without epilepsy cluster with low values, and people with epilepsy cluster with higher values of this susceptibility marker. And of course, as with all markers, there's overlap in the middle where you become uncertain. So I think that's pretty much what I wanted to tell you about this work. There are a number of people, actually, I was coming here, I wasn't sure what to expect, but there's actually a number of people in the audience who have really helped us along the way. So Neil Hayes from the University of Exeter, he's been instrumental in putting all the connections together from the impact, innovation and business perspective. Paul Shepherd, who reminded me that, you know, a few years ago when we first started this process, he met with Wes and I to listen to our ideas, give us some thoughts on how we might go down this. John Williams, who's been helping us with actually securing funding. Martin has been providing some great commercial insights, and Chrissy Walker, who I believe some of you know as well, joined our team about a year and a half ago as a project manager and has been pretty instrumental in making it all happen seamlessly for us, so us difficult academics can focus on being difficult, or doing research, as we like to call it. So listen, I'm actually going to stop there because Neil, I think, knows that I have a tendency to overrun, so actually told me that it was only a 10-minute talk rather than a 20-minute one. So I'm happy to take any questions, and as I said, we'll be around afterwards if you want to talk to us then. So thank you.
I do apologise for the movie. Obviously, the computer is clearly showing signs of late onset processing disorder. It's a shame we didn't spot it earlier. Has anybody got a question for John? Paul.
John, you mentioned that in your early studies that close family members showed very similar aberrancy or whatever to the epileptic people that subsequently in terms have epilepsy. Given that a diagnosis of epilepsy is a life-altering diagnosis in so many ways, when you apply your algorithm, if I can call it that, are you able to clearly differentiate the true epileptic from family members that show this predisposition?
Yeah, so that's a great question. So it's a two-stage process, if you like. So the first stage that we undertake is to pull out how the regions of the brain are connected without doing anything else. Now, if we stopped there, then that actually only gets us so far. So that enables us to identify people with epilepsy and also their relatives. So this is what the first study demonstrated. But then we go a step further, which is then we actually put a computational model that we can also tune through the data to understand specific subtleties of the dynamics of that model within the overall network. And when we simulate that model, this is what then enables us to more specifically identify people who clearly have epilepsy versus, for example, relatives or people without epilepsy in that case. So it's the combination of the network inference, so understanding how brains are connected, but as well as how the dynamics within those brain regions, so the electrical activity, how that evolves over time that enables us to make that diagnosis.
But is that on a patient-by-patient
Yeah.
basis, or is it generically?
Yeah, so this is on a basically, we create a patient-specific model using EEG data that is routinely acquired, but has shown no signs of epileptiform abnormalities from a clinical perspective. This is a good point, actually. Sorry, just to go on a little bit, but actually in terms of patient-specific versus group-level, so a lot of our analyses, when it comes to clinical analyses, is to consider group-level differences. So we take a cohort of people with a condition and a cohort without, and at the group level we see a nice effect, if you like. But actually, when you then translate that into an individual predictor, it can be absolutely hopeless. And this is something that actually comes out of some of the work that we looked at, because we did compare our methodology with all other markers that had shown at group level effects in terms of identifying cohorts of people with epilepsy and those without. And the marker that we developed, the computational marker, was the only one that was able to show meaningful predictions at the individual level, which is critical for diagnosis.
So I guess we need to watch this space. The company formation is imminent.
That's right.
Technology is patent pending, and you've got a core team behind it now.
That's right, yeah. So we're going to be hopefully taking it to launch later on this summer, which is really exciting. And as I said, we're looking to actually have not ourselves really running the show. I don't think that would be right or appropriate. You do get a lot of academics who like to play at being businessmen. I don't think that's really a sensible thing to do in this situation, because, as I mentioned, this is a really debilitating condition for lots and lots of people, and we can make, hopefully, with the technology we've developed, a massive difference to the lives of people with epilepsy. And we wouldn't want to muck that up by making lots of trivial mistakes as an academic.
Sorry, just a small question.
Sure.
So I have epilepsy, so I've had it for a very long time. When I first was diagnosed, they told me it wasn't genetic, and that was very much the idea that you had a bang on the head when you were a child, or all that sort of stuff. Now they would say it very much is likely to be genetic. Going forward, when I've got children, I've got young children, do you think that there could be something with the kind of work you do that would allow the testing in advance of family members to see if there is a propensity to possibly develop it, just so that, I went through a 2-year diagnosis, which was pretty grim at the time. Do you think that maybe something in the future would allow to say, actually, let's have a look at families, let's see where they are, is there a propensity, is there a risk, and therefore should we do investigations earlier and catch it sooner and get it treated earlier?
Absolutely. So we could certainly identify a susceptibility using the techniques we developed. The question then becomes, so part of it would then become a health economic question. So that would be if we prescribe drugs early for someone who at the moment apparently didn't have epilepsy, is that a health economically viable decision to make? I would say yes, it probably is, because a lot of the drugs for epilepsy are off patent. In fact, there haven't been really any blockbuster, inverted commas, new drugs developed in the epilepsy space for quite a long time, and that's something that pharma are really interested in. But there is another more practical question, which is, or practical issue, which is that many of these anti-epilepsy drugs have pretty serious side effects, and it would probably then come down to more of a sort of risk to benefit analysis, right? So I guess you could imagine, for example, here, if you imagine this scale is sort of risk factor, so if you were sort of right up this end, it might be worth prescribing anti-epilepsy drugs, even though at this point in time this was, not someone with an active, as would currently be clinically described, diagnosis. So, I mean, it gets really back, I think, to what do we actually mean by a diagnosis of epilepsy? Because we could say, using this sorts of analysis, this is characterising someone with epilepsy, even though we haven't necessarily observed a seizure. And if we put them on treatment immediately, we might never observe a seizure. And then, of course, you have various philosophical and ethical challenges around that sort of approach.
That's some serious life-changing effects as well.
Yeah.
Just the ability to drive and that type of thing.
True, although in that case, the DVLA have got slightly more pragmatic about the situation, and if you can demonstrate that you haven't had a seizure for a 12-month period, you can remain on anti-epilepsy drugs and still receive a driving licence. So there are sort of changes afoot there. But that's another, again, set of issues, because often these things are done on patient self-report, and patient self-report is not actually a terribly reliable indicator in both ways. You have some people who say they're having lots of seizures when in fact they don't seem to be having any, and conversely people say I'm not having seizures but in fact are, because often seizures are associated with short-term memory loss post-seizure. You just don't remember that you've had a seizure. Seizures can occur during particular times of day, so during sleep for example, where you just won't be aware.
Thank you. John, that was brilliant. Thank you very much. So, I really don't have anything left to say, to be quite honest. Thank you so much. Thank you so much to our presenters today. I think this has been one of the best presentations in a sense, as it seemed to logically flow from one to the other and back again. And I very much hope that if you've got questions, do come and ask them afterwards, and if you see opportunities, whether to get involved in a study or whether to refer others who may actually be interested in that, or even to spread best practice, then do, please, come and join us. Thank you so much.
When are you off to Cornwall?
I am already.
Well,
I'm not leaving.
Okay.
To Bishop. It takes me about